Good morning, everybody, and happy Friday, and welcome to this week's AMSSM Sports Ultrasound case series. We are back on our rotation of phenomenal fellows giving presentations now, and that will be the case for the next 5 to 6 months or so. So today we're really fortunate and lucky for the second presentation in a row. We've got more Stanford folks here. So we've got Cameron Fausett and Kuwabara and Jessica Tsao from Stanford. They're the current sports medicine fellows out there. And they're going to be talking today a bit of a different case, which actually I'm really excited about this because I think a lot of us see this, and there's some really good literature on this. I'd be interested to hear their take on this, but they're going to be talking about the sonographic evaluation of medial tibial stress syndrome. So with that, I'll let you guys take over screen sharing and get going.
All right, sounds great. All right, can you see our presentation okay?
Yeah, we can. Looks great.
All right, so yes, thanks for the introduction, Dr. Cruz. My name is Annie, or Ann Kuwabara, and I'll be presenting first. So we have no disclosures, and I'm just going to give some background about bone stress injuries. So bone stress injuries are overuse injuries due to an imbalance of excessive bone damage and inadequate repair. They're often commonly seen in runners and military recruits, but also among new athletes, people who have recently started more intensive physical activity. And bone stress injuries account for 10% of all sports-related injuries and have an incidence of about 20% in college runners. And early identification is critical for preventing progression to higher grade bone stress injuries, requiring longer times, ultimately out of practice and competition. And there's a continuum of bone stress injuries, varying from bony edema to full fracture. And as these injuries progress along the continuum, it takes longer and longer to recover. And there's also different classes of anatomical locations, low, medium, and high, and this is based on the bone blood supply and loading forces to the bone. And risk factors for bone stress injuries can roughly be divided into 4 categories based on intrinsic or extrinsic factors to the athlete, as well as non-modifiable and modifiable factors. So just to briefly go over some of factors, demographics can include females are at higher risks, as well as being Caucasian ethnicity and having a history of stress fractures, predisposed to more stress fractures, and genetic predisposition, including people who have maybe genetic polymorphisms that place them at higher risk of developing osteoporosis. And pes cavus or pes planus is an important risk factor because a more rigid foot makes more forces distributed to the tibia, for example. And some modifiable intrinsic risk factors include relative energy deficiency syndrome, low energy availability, plus or minus disordered eating, hypothalamic amenorrhea, osteoporosis, calcium and vitamin D deficiency, having a low BMI, poor or improper biomechanics or strength imbalance, and certain medications like contraceptives, corticosteroids like prednisone, substance abuse, including tobacco and alcohol. And extrinsic non-modifiable risk factors, so similar to being a new athlete and getting into more intensive activity, during the preseason, people are often ramping up at a rapid pace. And extrinsic modifiable factors are training variables, so trying to ramp up the volume in a more progressive way. And then people are at higher risk training on a non-compliant or uneven surface. And equipment variables like having an old or non-supportive shoe wear, and sports that gravitate towards leanness are also at higher risk, such as track and field, cross country, and gymnastics. And in the figure on the right hand, it just demonstrates that these risk factors all play together to increase or decrease your susceptibility to bone stress injury during training. And for diagnosis, MRI is currently the gold standard. So our own Dr. Fredrickson came up with the MRI grading scale that goes from 0 to 4. And 0 is normal, grade 1 is periosteal edema only, grade 2 is edema seen on T2 imaging, grade 3 is edema seen on both T1 and T2 imaging, and grade 4 is severe edema in multiple areas and includes full cortical fracture. And where does ultrasound come into all of this? So ultrasound can be used, and some benefits are specifically you're able to perform a dynamic exam so the athlete can tell you exactly where their pain is, so you can palpate over that area. It's also low cost compared to the other modalities and can be done point of care at the bedside and doesn't cause any radiation like CT or bone scan, and is less compromised by patient movement, metal artifact, or claustrophobia. And these are some things that Dr. Tsao will go into a little bit later, but similar to MRI, ultrasound can show findings of bone stress injury, including periosteal thickening, soft tissue edema, increased vascularity, bone callus, and cortical fracture. However, it can't assess structures deeper to the bone, such as the specific bone marrow edema seen in grade 2 and grade 3 MRI bone stress injuries. So now moving on to our case. Our case is an 18-year-old female collegiate cross-country runner who presents with 1 month of right shin pain described as a sharp, deep ache, and she does not have pain at rest, only when running and occasionally when walking. She has increased her volume of activity lately as she was in the preseason, and her risk factors include that she had a right metatarsal stress injury 1.5 years ago that has since healed. She's also had irregular periods over the last few months. She denies any weight changes and follows a regular diet. She's not on any medications except for magnesium and iron supplements, and she does not have any past medical or past surgical history. And moving on to the physical exam, pertinent positives was she does have a BMI on the lower side of 18.2. She also has pes planus bilaterally. And for her right tibia, she had some tenderness to palpation and percussion over the anterior and medial distal aspect of the right tibia. She had pain with a single leg hop test after 3 hops, and she also had a positive Fulcrum test as seen in the bottom right-hand corner. And for her next steps, we ultimately got an MRI of her tibia. We got leg length x-rays to assess for any discrepancy. And we also got lab work looking at some of those risk factors, including bone health, vitamin D, alkaline phosphatase, endocrine labs, including estradiol, FSH, LH, free T3, and some nutritional labs like CBC to assess for anemia, CMP to assess for any electrolyte abnormalities, and her liver function tests, and ferritin to assess for her iron status. And in regards to her activity level, we placed her out of practice in competition and non-weight bearing in a short walking boot for 2 weeks. And what her MRI showed was it did show some focal areas of subcortical bone marrow edema throughout the tibial diaphysis around where her skin marker was. And it was present both on T2 and T1 imaging, making this ultimately a grade 3 tibial stress injury. And here's an image of, here are MRI images. So the sagittal view is on the left, axial view is on the right. And now I'll hand it over to Dr. Cameron Fausett.
So good morning. So I'm going to be discussing a proposed ultrasound technique and protocol when you have a suspicion for one of these injuries. I'm going to be discussing how to go about scanning for this, regardless of where your concern for the injury is. So it's not specific to the tibia here, but just some things to be thinking about regardless of where throughout the lower extremity or elsewhere that you're worried about with your athletes. So in terms of our equipment, we do really favor a high frequency linear probe. Oftentimes these structures that we're going to be trying to visualize with ultrasound are going to be very superficial. So the linear probe is usually your best bet. We do see a fair number of these stress injuries in our rowers as well. They tend to get them on the ribs. That's kind of one of the pathognomonic injuries for rowers. So in a thinner bone, a smaller bone, you could consider using. Patient positioning is absolutely key when looking for these injuries. The great thing about ultrasound is that it's dynamic, but perhaps one of the bad things about ultrasound is that it's dynamic, and just as soon as you've got a pretty good image on the screen, your athlete shifts positions and moves, and then you have to kind of start all over again. So getting your patient comfortable in a place where they can remain still for a while as you're doing the scan is really key. Specifically for the tibia, I like to put them in external rotation or maybe even like a Faber or figure 4 position to kind of get better access to the posterior medial aspect of the tibia. That helps to visualize that a little bit better. And then I really like using a skin marker over the specific area of where they are tender. You can even have them kind of, if you're not concerned about a high grade injury or a high risk location, you can even have them hop up and down on one leg or do something to kind of reproduce their pain so that they can really hone in with preferably just one single finger to point exactly where they're tender. And then you can mark that as a frame of reference. Once you begin scanning, image optimization is really important. As we're going to see, some of this pathology can be very subtle. And so making sure that you've done everything to make your images as clear as possible is really important. Again, these structures are usually fairly superficial, so decreasing the depth to maximize the cortex on the screen is important. Adjusting your gain to make the cortex as bright as possible and to make sure that your focal zones are in the appropriate area for the cortex to try and highlight normal from abnormal pathology. This is one of my images. I'm trying to show that it's, perhaps a little bit shaky handed here. But otherwise the cortex is bright. The cortex is in the middle of the screen. I've tried to minimize the dead space here. It's a little bit blurry because I think I was moved as I was trying to take the picture, but otherwise, you're really not seeing a lot of extra tissue or area of the screen. It's really mostly just the cortex. And then in terms of scanning and trying to find normal versus abnormal pathology, I like to start away from the area of maximal tenderness and then to kind of get used to normal anatomy. And then slowly scan towards the area where they're hurting. I have to stop and emphasize that going slow is really, really important here. If you're anything like me, I tend to get excited that I might be potentially diagnosing a fracture with ultrasound, and I start to feel like this is the culmination of my training, and then I just go way too fast, and it's harder for me to distinguish normal from abnormal. This is just my own personal preference, but I like to start long axis to the cortex of the bone. I feel like that's the best way in order to kind of get the best sense of what's normal, what's abnormal, and so I can start to pick up on any differences in pathology. If and when you do start to see something that is concerning for a stress injury or a stress fracture, make sure that you are close to where their area of tenderness is. It doesn't have to be perfectly corresponding with your mark, but it should be fairly close. Most of these injuries are fairly focal. If you're far, far away from the mark and you're starting to see something that looks strange, then your degree of your index of suspicion should be lower, that perhaps you're not on the right spot and that's not actually the problem, what you're seeing. And then once you are over an area that looks suspicious, try and confirm it by looking at in the opposite axis. So if you're long axis to the cortex, swiveling the probe 90 degrees to get into short axis to see if you can see similar pathology or changes in that second axis to confirm it. And then this is a tip more for the residents and fellows who might be watching. Once you've got a good picture on the screen, of course, try to save that if you have the capability, and then consider making an additional skin mark so you can find it again when your attending comes back into the room. And then, of course, don't forget about the big picture that you might discover other or concurrent pathology that perhaps you weren't initially worried about. Maybe you started thinking that this was a bone stress injury, but you begin to scan and you find something like a hematoma as pictured here, or something like a tendinopathy or tendon tear. So just be aware that there are other things other than bone stress injuries, even though that's maybe why you started the ultrasound in the first place. So this is a proposed diagnostic algorithm for how ultrasound can fit in to diagnosing and helping manage these injuries. So currently, the kind of gold standard diagnostic algorithm is to get x-rays first, and then if those are negative, then proceed with MRI. So ultrasound isn't always involved in this. One proposed algorithm here is that if your first imaging modality could and perhaps should be ultrasound, if you do see something that is concerning for a high-grade injury, and Dr. Tsao is going to go over some of those imaging findings. So if you do see something that's high-grade, like a fracture line, et cetera, consider getting an MRI. In fact, you should get an MRI to then further characterize the extent of the injury and see truly what it is that you're up against in its totality. If you find ultrasound evidence of like a lower grade stress injury, then you probably don't need to go to MRI necessarily. You can probably just make the diagnosis then and there, and then begin treatment, and then follow them up with serial ultrasounds. So that's just one way that ultrasound can be incorporated into these injuries. And I'll turn it over to Dr. Tsao to discuss some of these ultrasound findings.
Thanks. Yeah, so I'm Jessica, one of the fellows. So I'm going to be talking about some of the things to look for on ultrasound before we get to our case. So what you might find on ultrasound. So again, kind of as Annie mentioned, so ultrasound findings similar to MRI, you're looking for periosteal thickening or elevation. You can see a calcified bone callus or other cortical irregularities or defects. As well as sometimes, this more superficial subcutaneous edema. And then using specifically color Doppler, we can look for hypervascularity, both in sort of the superficial tissues, as well as the periosteum and the bone itself. And I just wanted to note that the expected findings can vary depending on the stage of healing. I don't want to go through this entire table, but just highlight that the findings change based on where you are with the injury, which can actually potentially make ultrasound helpful to track healing. Early stages, you're going to see more of that like hypervascularity. You may see the cortical disruption, the hypoechoic fluid collections, some periosteal elevation edema, and then sort of later on, that's when you start to see callus formation, and you can also see some increased posterior shadowing behind the cortex. And then this is some of our kind of internal data, but how good is ultrasound at detecting bony stress injuries? So overall sensitivity of about 80%, specificity is about 70% when compared to MRI. And then looking at some of the specific markers, so periosteal thickening and subcutaneous edema were the most sensitive for detecting bony stress injury with around 80% sensitivity. And then bony callus, cortical irregularities, as well as periosteal elevation were very specific. So had specificity, basically 85% and greater. So if you see those things, it's definitely indicative of a stress injury. So now we'll kind of go through some of the early the changes and what you'll see, what they actually look like. Here on the screen is an example of changes that can be seen, particularly in an early stress fracture. So figure A shows some soft tissue edema It's kind of the curved white arrow. You can also see this hypoechoic periosteal edema with the white arrowhead, but kind of right above the cortex. And then the bottom figure, figure B, just shows an example of a lot of increased vascularity of the periosteum when using color Doppler. And this, I think, is a really great image, but these findings are pretty obvious when you look at it. And oftentimes you can have much subtler images. So this is example, this is one of our athletes with a fibular stress injury. And this is, shows a little bit of increased vascularity here, but again, it's pretty quick. I don't know if we can replay. So, it's not quite as obvious compared to the other image. In low-grade stress injuries in particular, you may not really even see hypervascularity. You may just see some periosteal hypoechogenicity, cortical thickening. So these are some examples sort of where you can see that sort of hypoechoic space right above the bone. But again, if you're scanning too fast or, not looking closely right over that area, it's pretty easy to miss these. And then in looking at high grade injuries, so this is pretty rare to actually see this, but if you do, obviously it's pretty impressive. So you can see these are examples of high grade cortical disruption. You can see basically the fracture line on ultrasound. And then as Kim mentioned, if you do see this, you probably want to get an MRI just to assess, the extent of the injury and help with prognostication. This is an example here of posterior shadowing. And so this happens, beneath the damaged or healing cortex. On the left, you can see there's, a little bit of callus formation with the arrowhead. And then kind of behind it is just darker compared to the rest of the bone. And then the image on the right, it's a little bit more impressive. You can really see the posterior acoustic shadowing. This one's kind of a cool image because this is a metatarsal. And so the Roman numerals 2 and 4, those are normal metatarsals. And then the one in the middle is where the injury is. So you can see like what a normal one looks like compared to what the injured one looks like. And then sort of as people move along the continuum in terms of healing, so that's when you'll start to see callus formation and you'll see kind of resolution of these earlier changes. So you'll see less edema, less vascularity. These are all kind of just some typical images showing later findings. The one on the right is, I think, after about like 80 days, so basically the athlete has healed. And then again, just to highlight that the ability to track these injuries over time, I think, argues for the potential use of ultrasound to kind of monitor and track the healing process. Yeah, so now that we've kind of gone through what to look for, we'll kind of bring it back to our case and go through our actual images. All right. So yeah, moving on to the case. So this is our patient's right tibia. So as you can see, I'm not sure if you can see my cursor, but there's definitely some edema, and I have the normal picture on this slide here. So you can see that there's definitely a lot of edema, a little bit of cortical irregularity and thickening. But we don't see any break, and we do have a video coming up. So here's this video. And then here's a video of the normal side on the left. So a lot more smooth, less irregularity, no edema compared to the other side. And then for her, since we got an MRI and she came back a couple weeks later, she's in that 10 to 14 day range. So we didn't see significant hypervascularity findings. And then here's some images in short access. As Dr. Cameron Fausett mentioned earlier, there's it's definitely easier to see in the long axis versus the short axis view. So this is compared to the left side. It looked pretty equivocal to us. And then to wrap things up with the report, so examination, this is an ultrasound of the patient's right tibia, and it was a follow-up on right medial tibial stress syndrome. Our specific findings were periosseal edema, cortical irregularity and thickening, and some callus formation seen over the right tibia at the location of maximal pain without evidence of hypervascularity. No fracture was identified. Our impression was this is a bone stress injury of the right tibia, consistent with MRI findings. And to wrap up our case, so for her management as a grade 3 right distal tibia bone stress injury, she was placed in a non-weight bearing short walking boot for 2 weeks. And after she was pain-free with ambulation, she came into clinic and we assessed her and made sure she had no pain with provocative maneuvers on physical exam. And then we cleared her to return to run through our Ultra G progression. And because she had oligomenoria, we also referred her to our nutrition and endocrinology teams to optimize her diet and nutrition and see if she needs any additional supplementation. And then because she did have a history of pes planus or flat feet bilaterally, we did refer her to get fitted with custom orthotics. And we'd like to acknowledge our Stanford athletes for letting us scan their bone stress injury areas. And we'd also like to thank Dr. Isaac Syrup and Dr. Michael Fredrickson for sharing some additional ultrasound images and some of their preliminary data. And here are our references. And thank you for your attention. We'd like to open the floor to questions now.
All right, great job, guys. That was, very thorough. It was a great overview of ultrasound for these bony stress injuries. I'll just make, excuse me, a couple comments, kind of based on my practice and my experience here. But I think that ultrasound, for evaluation of a bony stress injury is highly valuable. And especially as a screening tool. We can use this in the athletic training room if any of these athletes, come in with concerns for stress injuries. So I think that's a significant utility of ultrasound for these. There's really good data out there that, certainly ultrasound is more sensitive than radiographs. And while MRI continues to be gold standard, the sensitivity of ultrasound, in the 80% range or so is certainly nothing to discount there. When I see these patients, and I think this is pretty standard for most folks, what I typically see is that early on, they're going to have periosteal edema or elevation as well as hyperemia. And those are usually what I see as the first signs of a bony stress injury in ultrasound. However, the cortical thickening is also something that you're going to see early on. I also think that using ultrasound can be helpful to a certain degree to provide some sort of grading for these injuries. Obviously, if you're seeing a cortical break, that's a grade 4 injury, and ultrasound can be helpful with that. I've also seen or found that sometimes looking for periosteal hyperemia can be a little challenging. Because, certainly, like Pam mentioned previously, if you're moving the transducer at all, you're going to get some Doppler artifact, and you really have to, make sure your hand is steady when you're looking for hyperemia. On our machines, we've got SMI or superb microvascular imaging, which is highly sensitive for slow flow vessels. So I've been super happy using that for detection of hyperemia because, again, it can be fairly subtle. I think that's all I had. I don't know, Doug, do you want to make some comments? I know you've got a couple papers on this.
Yeah, just to be clear, that we're all on the same page. Medial tibial stress syndrome is simply just a continuum of a stress injury. Is everybody in agreement to that?
Mm-hmm. Yes.
So one thing, so this is a series on ultrasound and protocols, and the protocol of this would be brief if we're going to be limited to the lower leg. So, we're going to scan the tibia carefully, long and short axis. We'll probably look at some of the muscle attachments, and that's been studied under ultrasound, and some debate of what muscle attachments may be contributing to the stress injury, if at all. So you're going to want to look for other things in part of your protocol, but it wouldn't really meet criteria for complete exam until you have a joint in there. I mean, there's nerve in there. And so you could scan, if you wanted to do a complete protocol, you could just scan down to the medial tarsal tunnel and you got everything you need. And I do that often with my plantar fascia or Achilles protocol when I need joint. Just a couple of things in scanning, and that is that we have nutrient arteries that are often seen in the tibia. And so you're going to see a little vascularity. And so it's important to make sure that you're seeing just a single nutrient artery. Often, if you're really sensitive, you're going to see the artery and vein go through the cortex, and don't mistake that with, with an abnormal cortex. And almost always you're going to couple some Doppler or vascularity with some changes in the periosteum. So that's one distinguishing factor. I've noticed that hematomas because you had put that up, hematomas in the shin area, anterior tibial area, can be permanent. So you have permanent, in a sense, thickening or fracturing of the subcutaneous fat. So even several years later, you can see sonographic abnormalities. So that's something to keep in mind, that those changes may be permanent. And then finally, I'm struggling a little bit to understand, the specificity of this and sensitivity. There was a study back a few years ago out of the Netherlands showing that periosteal thickening, periosteal edema, and even Doppler activity was as prevalent on the contralateral asymptomatic side, or as prevalent in athletes or runners who don't have shin pain. And so, yeah, I think it can be a marker for further investigation, but in the tibial area, I'm wondering if these ultrasound findings, again, the sensitivity and specificity is questionable. I know you guys are doing some research on this, but I go back to that study. It was in 2017, and it really showed no change or differences with symptomatic and asymptomatic sides. So I'm sure you guys are aware of that study, and I don't know what your experience is, because you see a lot of this.
Yeah, so I mean, I think so. The numbers that we presented, that's kind of obviously I mentioned some unpublished data. So this was kind of in response to some of the other things that have been published, and so that's been, I think this data will be published in the not too distant future, but just kind of we were seeing much higher, sensitivity and specificity in our population, and it could be that just the differences in population versus the protocols, but we definitely we are scanning sort of both the symptomatic and non-symptomatic limbs, and then also comparing basically those findings. So people who had those findings with, everyone got MRI. So if you had a diagnosed stress injury on MRI, so we're comparing it to that as opposed to just like symptomatic versus non-symptomatic. But like I said, the data still unpublished, so I guess still kind of remains to be seen.
Yeah, and I mean, it's great you guys are doing that, because I think this is a very common problem in certain populations, and I like your logarithm, because I do think there is a role for ultrasound, but I agree that I think MR is really the definitive imaging test and the logarithm for management. And I wonder if you have a 100% normal tibial cortex, what is the the actual incidence that, there's early stress injury. And I think, I guess from my perspective, that would be the biggest question, is if you have 100% normal ultrasound, can you feel assured that you don't have an early stress injury? Because I don't think ultrasound is sensitive enough to say, okay, these findings, this is definitely a stress injury, but maybe then lead you to another imaging test.
Yeah, I mean, I think we would probably agree with that. If you have a high enough suspicion, that a normal ultrasound, you would probably still progress then to MRI, and it's kind of the middle category where you maybe see something, but it's not severe, where you can kind of just start treating it. So we do that oftentimes with our rib fractures and rowers, where they may not get confirmatory MRIs, but if you see, something kind of some like early changes or mild changes, then you just treat them as such.
Yeah. Have you, at Stanford, have you tried any type of like prolotherapy on these patients?
Not that I'm aware of, no.
Yeah.
There was an interesting study that came out last year that used ultrasound to guide prolotherapy right to the tibial cortex, and these were with recalcitrant athletes with shin pain, and that there were some flaws in the study and even with the diagnosis, which was mostly clinical, but again, it was interesting because in some ways, I think we think of these as unhealed, basically the inability of the bone to repair, especially in people with recalcitrant. For some reason, the bone's just not repairing itself. And so if that can be stimulated, so that was an interesting study of considering, because it's so accessible with ultrasound, to be very specific in our injection location.
There's a, oh, sorry, go ahead, Doug.
I was going to ask you, I mean, you see a lot of runners at Iowa. Do you have anything to add with treatment of that, or have you done any ultrasound guided procedures on these people?
Yeah, so first, I don't do any prolo here, so I certainly haven't done that. There have been a few, and not recently, but a few that I've treated with PRP, again, because I don't offer prolo, and I don't know, they've done fine. Now, does that have anything to do with the PRP, or is that just kind of their natural history and they would have gotten better regardless? I don't know. I think, there's potentially some role if somebody's struggling to get back, to, essentially, augment their healing and get them over the hump. But I don't know. I'm not overly convinced, at least at this point, that it makes a significant difference, injecting into that area. But again, that's just anecdotal evidence, in my opinion. So I guess there's one question here quickly, if you guys just want to comment on this. How do you think image quality on a portable machine versus a cart-based machine, especially with Doppler, affects your decision making?
Yeah, I think it's similar to what we said before. So since ultrasound is more of a screening tool as opposed to MRI, if you have a strong suspicion, even if you're not seeing any clear findings on ultrasound, we would still recommend going for the MRI. And then alternatively, if you do see higher grade features concerning for a fracture, we'd also recommend MRI. So just, more of a screening tool to help support your clinical suspicion.
But I do think that certainly on things like, say, a butterfly, it's going to be pretty challenging to get like really quality images. Otherwise, the sort of smaller portable ultrasound is probably a little better, but certainly, it is definitely more challenging with the more portable machines.
Yeah, especially
Just
for the lower grade injuries.
So just some nuts and bolts of the Doppler, because it is an important point with these injuries. So, using a fair amount of gel, because this is fairly close to the subcutaneous tissue, so it won't take much pressure to get a false negative with Doppler. So a fair amount of gel, and then just optimizing the Doppler gain, with whatever machine you're using by, turning it up, getting some of that speckled appearance, and then turning it down until that speckled appearance goes away. So, your image of the Doppler from Stefano Bianchi's paper back in 2018 on periosteo abnormalities, he's just a master at this, and every machine has a probe that seems to be better at Doppler. And so I know exactly what probe to use on those images, because I have the same machine and the same sensitivity that it's just better. And so maybe you might not have that option with the portable, but on your cart-based machines, you typically have probes. So with a fair amount of copious gel and being sensitive to the gain, you can definitely optimize that, which, seems prudent in this case. So this was a really good presentation and a really good, it can be really frustrating for clinicians and for patients to get better.
Yeah, great job, guys. This is a good topic and great conversation that you all stimulated afterwards. I think, yeah, we'll see where, it'd be interesting to see where this data, what the data looks like when you guys put that out, whenever that is, and seeing down the road if, I think my biggest question here is can ultrasound help with gradation, right? I mean, are there certain findings, and we're looking at this here. Are there certain sonographic findings that correlate with the classification based on MRI? So I think that's still to be seen. But anyways, again, great job, great case, great presentation. Thank you guys for getting up ungodly early on the West Coast to present, and hopefully you guys can go take a nap or get some coffee or something.
Thank you so much.
Thank you, everyone.
Yep, absolutely. All right, so that's it for today. We are off next week, and then we'll be back on the 25th. We've got Megan Burleson and Elizabeth Nguyen out of University of Washington. They're going to be talking about a case of tarsal tunnel. So again, that's on 2/25. Otherwise, happy Friday again. Everybody have a good weekend. And thank you, Stanford folks, for that talk.
All right.
See you guys.
Bye.